Okay, it's going.
All right. So I'm here, and let me bring up my phone. Maybe you can read that it says
Bonnie's here.
Bonnie slash MSN class is joining us via phone because she is at an undisclosed remote nursing location. But we're going to triumph and we're going to make it work, and we're going to talk about the DQ1 for week 4, looking over the screening, health promotion and counseling, evidence and recommendations. I was interested in looking at this because I, being a military dependent, I change locations quite frequently, and I get a new provider every couple of years, and they always want to know, hey, when was your last pap smear? And going to schedule it. And I've noticed in the past few years the change of the recommendation for how often you need to do it. I don't know if you guys have experienced the same thing, if you've had consistent healthcare providers, if you've seen a change.
Yeah, I mean, it seems like everybody you see says something different.
Right.
I don't have to do it anymore, praise the Lord.
Oh, okay, you've had a hysterectomy? Okay.
Thank you, Jesus. Best thing.
Yeah.
But, yeah, I mean, so at the end, I mean, it used to be every year, and then it was every 2 years.
Yes.
And then I think at the end they were saying every 5 years. But maybe
right.
that's because I was done having kids and I was in my 30s, and I don't know, but.
Yeah. I think some of the reasoning behind the changes was not, it was a low yield doing it every year. But I was familiar with the concept that they wanted to do a pelvic exam on you as part of your yearly physical.
Yeah.
You know, they're going to be doing a pelvic exam anyway. I say, you're doing a pelvic exam anyway, why not do the pap smear while you're there? Mm-hmm. So, but I think, and in looking up some of the things to support it, one figure that I came across was that it usually takes 3 to 7 years for high-grade changes in the cervical cells to become cancer.
Yep.
So doing it yearly, not yielding a lot of results. And depending on, you know, how good of a history your provider takes of you, and the clinical reliability of, I've never had a bad pap, so therefore I should continue on that course. Mm-hmm. So what do you think, Bonnie?
Well, my last pap I was doing every year, and my last pap came back abnormal. And I wanted, and they did the biopsy, and I wanted to do it Destiny. I don't want to wait a year, but she would not allow me to do it earlier. I wanted to do it every 6 months. I want to repeat in 6 months.
Yeah.
She said, no, we're just going to wait a year because normally the body takes care of these changes on its own. Mm-hmm. But it was very uncomfortable to know that they wanted to wait a year. In my mind, I was thinking, oh, that can happen in a year.
Sure.
So that year is just now approaching next month on my birthday, on the 5th. So I'm anxious to see myself because she no matter how much I begged, I wanted to, I didn't care about the insurance, no pay for it, I pay out of my pocket. It wouldn't do it.
Right. And I think that's an insurance issue as well. I looked at one of the CDC sites, and they have this HEDIS indicator, and it follows, you know, results of people that have Medicare and HMO. So, you know, obviously we're missing the people that are falling through the cracks anyway. So the data there not so much. But I'm like you. I would prefer to have it more frequently. But I know, just how people are with, you know, so many people probably avoid that just as much as they avoid other, breast cancer screening, or men avoid prostate screening, all of that, taboo, or afraid of what they might find.
Yep.
Or just afraid of the general procedure itself.
Mm-hmm.
Exactly. I think when it comes down to the HPV and so many different ideas in that is confusing itself, because they had started with doing the vaccine offered to females at age 12, but then when I see commercials of boys having it too,
right.
I don't see much testing or the vaccination for the boys. I don't think I've ever known a boy to get it, but I do know that they offer the females.
Right.
They said in the book that the Gardasil has 3 doses and it only targets 4 kinds of HPV, but there's like 70 different strains of it.
Right.
And it decreases the risk of genital warts. I have it written down. I'm reading my
notes.
And cancer. And they also recommend that if they didn't get it if they didn't get all 3 doses, if they're still less than 26 years old, they should have a catch-up vaccination.
Okay.
And it recommends boys ages 9 to 26 that they get it to prevent genital warts. Well, my boys have been raised to keep it in their pants, first of all, or put a raincoat on it.
Right.
They shouldn't need that. And
exactly.
They shouldn't need the vaccination because they shouldn't be promiscuous,
Yeah. That's the discussion that my husband and I are currently on the edge of. I'm not for the vaccine for our son. He doesn't mind one way or the other. So I was interested to see what you would say about that, Jody, because I know you have a son as well, don't you?
I have 4 boys.
4 boys. Okay.
Yeah.
So, yeah. And I know, like I'm a nurse and my husband's medical. And so our guy's probably going to be pretty scared of girls, because we're probably going to lay out the STD talk pretty tight.
You have graphic pictures.
Yes. Like in the book.
And
if any of your friends have a baby, make them babysit.
Yeah.
We didn't talk about it. Their father had a conversation with them, but they wasn't too intrigued on knowing the details. It kind of bothered me when I attempted to talk to them about it.
Yeah. I think that's interesting, and that's going to roll into our question for Thursday about taking a health history on a young person. I remember when my family practitioner was talking to me at age 16 and was like, no. Do you want your mother to leave the room? The answer is going to be the same, I mean, I respected that she thought I might, and probably most teenagers would maybe not say what was really going on if their parent was in the room. But, that's going to be one of them. So I think I agree with the Pap smear recommendation, and I think they're even getting and I looked at the ACOG recommendation, because the one that is quoted in the book is like a couple years ago. It's like 2000, or 12 or something. So I looked at ACOG site, and for February 2016. They were like, okay, they didn't change anything except they upped it to screen every 5 years as preferred for women aged 30 to 65. But then they also put, it is also acceptable to have a Pap alone at every 3 years. So I think they are leaving it up to
the doctor,
clinicians and their patients to hopefully have that discussion, and based on their history and their past results, to say, what are you more comfortable with?
The clean history, I'm assuming.
Yes. So So that was interesting, but I'm going to be interested in more of that HPV discussion as we go forward. So that was talking about that.
You know what kind of freaked me out in the book? Was the ovarian cancer.
Yeah.
The signs and symptoms are just abdominal distension, bloating, and urinary frequency. That's me.
Right. Yeah. Right.
That can be anything, any given day for any
yes.
kind of woman.
Yes. 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 This is like a flashback. I don't know if this happened to you guys in nursing school, but like you like thought that you had all these diseases that you had.
Yes.
Because every disease started with fatigue and loss of concentration. But
in my case, when I had an abnormal path and the symptoms be so vague, and then they force you to wait.
Yes.
It's very uncomfortable. It's I try not to think about it, but then when I do think about it, the worst thing comes in my mind.
Yes. Yes.
And it's been a very stressful year waiting for this one day next month. I mean,
yeah.
Because then they goes on to talk about the ovarian cancer is one of the hardest to treat.
Yeah.
And so why wait if it's hard to treat and the symptoms are so vague? You can be missed by so easily by anyone.
Yeah.
It's very uncomfortable to be in the situation and having to wait and all the other stuff be so vague. It's very, very uncomfortable.
Right.
I'm sure it's a lot of anxiety.
Yeah, exactly. The anxiety of I've had to be called back for a repeat mammogram, and then of course I'm of the fluffier size, so it is clinically harder for them to palpate my ovaries anyway. Mm-hmm. So I know that that's not really getting covered in a bimanual exam necessarily. So yeah, that is it's frightening that there's not some other test or indication for that. I don't know.
It's very worrisome. Mm-hmm. I think it would be eliminated. In my case, I can think of my case. I think I would much rather have this or perhaps every 6 months let me know if nothing has worsened. Mm-hmm. As opposed, just that piece would probably be more, I'm sure it would be more comforting than not knowing anything and having to wait. And then what if it's worse and what if it is? And how are you going to treat it? Because it doesn't look that promising,
Right.
I would much prefer her to allow me to have had it, but she wouldn't.
Yeah.
But no.
Mm-hmm.
Yep.
That was, they were talking a little bit about some of the cancer screening. The CA-125 testing was not specific for that. And I think a lot of that too, that's one of those kind of medical legal insurance kind of gray areas where if you get some of that genetic testing done, does then that become this, underlying, what is it called, the pre-existing, condition that they won't carry you for. So
it does. My grandmother had breast cancer. My mom had breast cancer at age 26. My aunts, my great aunts, was 4 ladies. All 4 of them had breast cancer, and my mom had it. Her sister has never been tested. She just refused to go. Uh-huh. So we don't know where she stands. And my sister, the same way, refused to go. Mm-hmm. So I've always gone and had mine done, but I wanted to do the genetic testing to see.
Yeah.
Mm-hmm. But I was told that if I did have the gene, it doesn't guarantee it, but my insurance, my being able to be covered for insurance, they would consider as pre-existing.
Right. So, and then that's almost like this anxiety that you're living under, waiting for that test too.
Right.
So
Right.
does that negatively impact, I am a big believer in the power of positive thinking with, disease process. So that's an interesting aspect of that for sure. What else was I thinking? That made me think of something else.
I kind of get what the insurance company is saying when it's
Mhm.
an expensive test and it's not specific.
Sure.
Really, it could possibly cause you more anxiety because
Mhm.
so I'm gonna get breast cancer
Right.
or whatever.
Right.
Yeah, it is. It does cause more anxiety, knowing if I had the gene, what, when, and how, where would it happen, how old would I be when it pops up out of nowhere.
Right.
So I'm sure it would increase my anxiety, but looking at so being so dominant in my mother's family that I think I'm living with anxiety anyway.
Sure. There's a possibility. I think what it was making me think of earlier was reading in the chapter about hysterectomy and hormone replacement therapy. The hormone replacement therapy does benefit you in some areas of disease, but then it is a detractor in some.
Right.
So,
that's happening in my family, but the hormone replacement was like a feeder to it.
Right.
Like my mom, she had a hysterectomy at an early age, and when she started the hormone replacement, maybe 2 years later is when she was diagnosed with it.
Yeah.
And so they did studies, a whole bunch of work on her, and said that hers was estrogen fed. So I avoid all that at all costs.
Yeah, right. And so, is it, that's the talk to have with your doctors, like, okay, well, it's going to help me with my risk of heart disease, but maybe if I don't have that much history of heart disease, if it is, an estrogen uptake, breast cancer, then yeah, you don't want to mess with that. So,
No.
but.
And really, that study that they talked about in the book said it didn't really do much for heart disease.
No.
For bone density, yes, but not.
Yeah.
So I don't know. I guess I don't think that the benefit's worth the risk.
Right. I thought they talked about it maybe just like for the first year or two, I guess, until you kind of get over that complete withdrawal of hormones, but I guess you'd have to experience the menopausal symptoms at some point anyway.
Right. I mean,
I don't think it's ever going to be something that a woman completely gets away from.
Right. Let's see. There were two other areas of recommendations. One was for the sexually transmitted diseases and HIV. Boy, definitely. I mean, I don't think anybody shouldn't have a problem with those recommendations.
I agree.
No.
That is something that, and especially with, some of it, even like some of them that can be tested through urine, and of course HIV through blood. So, patients shouldn't have that much resistance to a blood test or a urine test.
Yep.
Run in conjunction with other tests at some point, but it's getting them in for that yearly and having that talk. I'll be interested to read. I don't know that I've had much sexual history taking experience, so I'll be interested to get that and get some pointers on that. So
that's
and then the last one was the family planning, and that did include that talking to teenagers confidentiality that we had already talked about a little bit. So certainly there is an endless opportunities and options for family planning with the different implantables, and I know my husband does a lot of those at his work, and I've tried a couple of these on here, so, but I think it would be something, I'm not sure how much of that information, obviously some people's parents aren't giving them that information at home, and it's interesting to see what the school curriculum is for that. My son's in third grade now, or he's in fourth grade now. Last year in third grade, they sent home a piece of paper and they said, a nurse is going to come and they're going to talk to them. And I was like, this is way, 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 way too young. And they said, parents could come. So I went because I wanted to see what they were talking about in case he had questions at home. I was the only parent that went. And it was just a general introduction to anatomy and body parts. And so I went up afterwards and I talked to the nurse and I said, look, this was great. Thank you. I just didn't know, what the sequence is. And so she said, like, next year, like in fourth grade, they talk a little bit more like scientific, like the sperm and the egg meet, and this is how you get pregnant, but they don't talk about the physical act. And then in fifth grade, it's more the changes of your body and things like that. So, I think it really depends on where your children are going to school, what they're going to be exposed to. So then you end up with, maybe a teenager in your office that doesn't know how she got pregnant.
Yep. Yeah. Yeah, it's definitely something that's taking it away from the parents. The parents still need to talk to their kids.
Yes. Yeah.
The school's just trying to make sure that they have some basic information.
Mm-hmm.
My youngest came home.
I think that when it comes down to children educational sex, it really depends about the location where the children are.
Yeah.
In some areas, you will find that sex amongst children is very high.
Yeah.
And so I can understand why they start sex education early.
Sure.
I can remember when I was in the 6th grade, I had a classmate who was pregnant.
Wow.
She's 12 years old, having a baby.
Mm-hmm.
And it was not at all uncommon to see 15, 16-year-olds starting families, and by the time they're 17, they're on their second or third baby.
Right.
So that's not unusual in some neighborhoods, some societies.
Mm-hmm. Yeah, that was interesting. Like the first, is it like 20? Was it 21 or 25? Was the recommendation for the first Pap smear? But it doesn't relate that to, unless sexually active for, should there be a caveat to that of like?
There is.
Is there? Okay.
So it said that the first one,
a lot can happen that time frame.
They said that the first one was for 21 years old.
Yeah. Oh, okay.
Indications for pelvic exam in adolescents, and listed a bunch: amenorrhea,
okay,
excessive bleeding, dysmenorrhea, sexually active.
Okay.
It listed a bunch of stuff. But
okay.
In there.
Okay.
Indications for younger.
Yes. So I wonder if they would like put a time frame though on it, like saying like if you've been sexually active, one time, then you need one.
Well, if they've been sexually active one time, they're probably
going to continue. Right.
I think if a female is sexually active, then they should do Pap smears.
Right.
I mean, no matter how old they are.
Yeah.
Because the disease process is going to be the same.
Right.
If this 6-year-old has contracted an STD, it will run the same course it would a 25-year-old.
Mm-hmm.
So I don't think waiting till someone's a special age to offer preventative care or informative care, I don't agree with that.
Right.
Because, teenage pregnancy is at an all-time high.
Mm-hmm. Mm-hmm.
We may not act as if it isn't.
Yeah. And I think you've probably all seen patients, though, that were opposed to having an exam, but that they have been active.
Yeah.
So it's like, if you are going to behave in an adult manner as to having sex, then we have to perform a test that we perform on anyone.
Yeah.
And so that's part of being an adult, is having to have that exam to make sure that everything is okay.
Yeah.
And a part of that for sometimes in my career would probably be definitely being empathetic and withholding cultural judgment from, saying like, oh my gosh, I have a laboring mom who is 14.
Mm-hmm.
So, and struggling to get pregnant myself, and here is a teenager that it's just fell in her lap. So, yeah, I need to keep that in mind for teaching our students to be accepting and understanding of a younger patient that's further along
and
in their experience.
Yeah. I think that the hard part with that is just trying to take out your own values.
Yes, yes.
And you can't always blame the child because they maybe are raising themselves.
Right. What example did they have? And if that's what they know, then that's how they've lived. So
that's how I have to tell myself.
Mm-hmm.
Exactly.
Yeah. So, all right.
So we had a couple more questions. So
yes.
Was so are the recommendations current? And you said yes, pretty much they were, right?
Yeah, I looked, and there was only that one year change, but it wasn't even necessarily a definitive. And my husband and I have talked about that too. It's it's kind of up to the clinician to say, but it's still within a 3 to 5 years. It's acceptable. I think if the insurance and allows it, and the clinical needs present, then you can do it then.
Yep, definitely. Okay. The next one was, how will you use this information in your own nursing practice and your future practice as a nurse educator or nurse practitioner?
Great.
I didn't hear what she said.
Okay. She was going over the our written response is going to cover this too, but how would you use these recommendations in your teaching?
I think
I would teach my audience that, without passing judgment or just not supporting or judging, just providing information.
Right.
That if you are, and they would know if they are, these are what's available to you.
Mm-hmm.
If you aren't, I wouldn't cheer and say, yay, great, that's how you do it. I wouldn't do it either. But I would kind of really stick, really just presenting the facts.
Yeah.
If you are, this is available, this is a recommendation. If you aren't, that's your choice, your preference. But if you become, it's still the same thing.
Yeah.
As far as agreeing with what recommendations, because of my own personal situation, I don't agree with them.
Mm-hmm.
Because of the scare that I'm living with on my own.
Mm-hmm.
I don't really agree with the recommendations.
Yeah. And I think I would use them as, in teaching about the different disease process. If we talk about, what is HIV, what is chlamydia, what is all of these different things, saying this is when you should screen for it and how often that it should be screened for, but also to, be teaching the future nurses the health advocacy role of informing patients, if they are taking a health history, even if it's for something unrelated. But there's so many you know, sometimes a GYN complaint presents as an abdominal complaint, or vice versa, you know, some of that referred pain that we've been talking about, you know, just saying, you know, to rule out these things, these are the, you know, screenings for it. And, you know, just as recommending, you know, breast self-exam and a mammography and colonoscopy and all of the. You there?
Yeah.
Okay. Hot mic. I think you're in a missile bunker in North Korea.
Oh. I had to let an ambulance out.
Okay.
Take his phone out.
Okay. All right. Well, Jody, how are we doing on time?
It doesn't keep track, but I think we've got to be close.
I think so.
We can talk about just the last one was, why is it important that we teach our graduate students current evidence-based practice, really just to protect themselves?
Yes.
You know, from lawsuits.
Yeah.
They want to do the best job they can for their patients, and
right.
your patients expect it.
Yes.
So, I mean,
I agree to that. I agree to that.
Yeah. Have you been on the UpToDate medical website?
Well, I haven't since I started teaching, but we had
okay.
It, that was part of our intranet.
Yeah, okay.
So that we didn't have access to the internet, but we did have UpToDate on there.
Have UpToDate on it. So yeah, you know, and that's, you know, some of the journal articles that come in professional journals, you know, or different things, you know, it like totally surprises me to see some of the new recommendations to come out that are, you know, so vastly different from, you know, maybe things that we learned quite a while ago. So, you know, staying current does definitely protect you legally and help, you know, provide, because, you know, maybe that gives great comfort to your patient to say, hey, I don't have to do a pap smear on you for another 5 years, you know. Are they gonna, you know, they're gonna make their yearly appointment and say, whew, this year I don't have to, you know, at least I don't have to do that. So
when ACLS isn't due that year, you get really excited.
Right. So yeah, so definitely, you know, you never know what tricks you're going to learn from somebody else, but, you know, that they've done the research, that you've evaluated that research to be credible.
Yeah.
And, you know, just taking a pearl of wisdom from somebody else that, you know, maybe sees this more than we do.
Right. All right, ladies. Well, I think that's pretty awesome.
I think we hope we covered it. So, Bonnie, with your permission, we can stop recording.
Yes, ma'am.
Okay.
All right, Bonnie. I hope everything works out well at work.
I'm so glad. I see them putting their things in their little carry-on bag. I'm so ready for them to go. They came in here at 9:30 and they've been here all day.
Oh gosh, that's a long day.
I'm sorry.
And the sign said they're going to be here till Thursday. You know, I was supposed to get 30 days off. I flew home. I was home 2 days, and they called and said the hurricane and they was evacuated. And this building has 160 residents. Okay. I had to come all the way back. The government said evacuate all long-term care facilities, all hospitals, organize to get all these people somewhere to go and how to get there. Then he canceled at 10 o'clock.
Yeah.
Then at 2 o'clock, he made it mandatory again. So I had to rush to get all those people back situated, church station back available, get here, start loading up. I think we had like 38 people on the buses, and he canceled again. I said, this man is really getting so fucking lame. So we didn't evacuate after all of that.
Okay. Oh gosh.
But it did rain really, really bad.
Yeah.
Tore down some trees and things.
Yeah. Yeah.
All I had to deal with was no electricity last Monday, so.
Oh, okay. Oh, yeah, gosh, you had some of it too. So, okay, hold on one second, Bunny. We're gonna stop recording.
Okay.